Dr. Paul Sylvian, sir. So Dr. Paul Sylvian, sir, is working as the assistant professor, and he is the head and program head for the program physical therapy department of medical rehabilitation sciences in the College of Applied Medical Sciences, King Khalid University. And sir has experience of 17 years of experience in physiotherapy teaching, guidance, mentoring, and clinical department. We welcome you, sir. A very warm welcome.
Thank you.
Okay, sir. We can start with the session, sir.
Yes, today we are going to discuss about, good morning to all. And today we are going to discuss about evidence-based physiotherapy, a process for critical appraisal of evidence. So basically in physiotherapy practice, we use evidence. We try to search for evidence and practice effectively. So evidence-based physiotherapy is physiotherapy informed by relevant, high quality clinical research. So what all researchers have been conducted, you search for the research and then you practice effectively. But the problem with this evidence-based physical therapy or physiotherapy is that high quality clinical research is not only information required for practice, effective practice. There are several reasons for this. One of it is, the most obvious is that research alone does not make good or bad decisions, but people do. When they practice, they can do mistakes. So when patients, health professionals, and policymakers make healthcare decisions, they bring to their decisions a range of values, preferences, experiences, and knowledge. So thus, decision-making in physiotherapy practice, as with any other aspect of healthcare, is a complex process, especially when it comes to patient preferences and physiotherapist practice knowledge. So therefore, high quality clinical research is therefore essential for evidence-based practice, but the practice should be based on more than just evidence. You should use evidence along with your practice knowledge, patient preference, and professional ethical way. Can you please move on to the next slide? So how important is evidence-based physiotherapy? So for the patient, we try to give them the safest and most effective intervention. And we also supply them with reliable information. For physiotherapy, as a physiotherapist, we have to be trustworthy, we have to be professional, we have to have high ethical standards, we have to practice high ethical standards, and we have to do our best for the patients and for the society. For funders, decision on investment of healthcare services need to be based on pure evidence. Can we move on? So how do you practice evidence-based physiotherapy? It should be practiced and informed by the three things: high quality clinical research, your professional knowledge, and patient preference. These are the three things with which you'll practice with evidence. Can you move on to the next slide? So what is high quality clinical research? We try to search for evidence. We see a lot of research articles published in very many journals. So we need to see whether the high quality means it should be trusted and relevant to our questions. So we have 4 questions. Can we move on to the next slide? We have questions pertaining to our clinical practice, that is the effect of intervention, attitudes and experiences of patient, prognosis, and to identify the accuracy of diagnostic test. So these are the 4 main questions we'll be addressing today, and we'll be critically analyzing it. So if you take research design, so we've come across a lot of research articles and various types of research have been done with a lot of research designs included. So based on that, well-designed research can produce relatively unbiased answers to our clinical queries. So when there is a poorly designed research, it can generate biased answers. What is bias? Bias is nothing but the one way of defining bias, that is, it is systematic deviation from the truth. So it doesn't tell us the truth, it goes in the false direction or in the negative direction. So readers of clinical research literature, when you're searching for evidence, you need to be able to discriminate between a well-designed and poorly designed research. Can we move on to the next slide? Yeah, if you see, this is the pyramid of evidence. You have level 1, and level 1 you have meta-analysis, systematic review, and randomized control trial. And level 2, level 3, level 4, level 5, you have this cohort, case control studies, case series, case reports, animal research, in vitro research, everything. But if you come across meta-analysis, systematic review, randomized control trials, mostly it is experimental studies, whereas other cohort studies and the case control, case series are going to be in observational studies. So what we are going to do is, we are mainly focusing on high quality clinical research. So this is where you need to search for studies in the level 1 evidence. That is, it is going to be randomized control trials and systematic review. As you all know, you compile very many literature pertaining to a particular topic and then summarize it and give a result. Same way, meta-analysis includes the data and then summarizes the result for a particular topic. So we'll be dealing or getting information or evidence from randomized control trials, systematic reviews, and meta-analysis. And also other studies like cohort, case control can also be used. So we'll discuss more about it in detail when we appraise or when we do the critical appraisal. So many physiotherapists experience a common frustration when they consult the research literature for any answers to clinical queries. They are confronted by a range of studies with different conclusions. If you search for one particular topic, you'll have different conclusions given by the authors. So that is where you get confused. Which is the final solution? Which is the final answer for me? So that is where you try to think and don't know which study to take. So why there is so much of inconsistency in the literature? The research articles you take and see the answers, the conclusions are mixed and different. So there are several possible explanations for this. First, there may be important differences between the studies. Like, for example, the patient population included might be different. The way in which the intervention was administered, the type of intervention or the method or the technique, and the way in which the outcomes were measured. So sometimes some authors use different type of outcomes, some authors use different area, or they try to differentiate or put some validated or some outcome measures which are based on their own research. So that is where it differs. So simple conclusions may obscure important details about patients, interventions, and outcomes. Another important cause of inconsistency is bias. Many studies are poorly designed. So if the design is not good, it can lead to bad or biased conclusions. So the findings of poorly designed studies and well-controlled studies of the same intervention can differ very markedly. So studies which are like using the designs wrongly, or if they are not doing it proper way or not understanding, it can lead to problem. So we should not demand perfection from clinical research because it is generally not attainable. Instead, we should look for studies that are good enough for clinical decision making when you are practicing. So critical appraisal, we have to, do I trust the findings? And can I use the research in my setting? That is why we do a critical appraisal, or we critically analyze the literature and extract the information which is required for you to practice effectively. So critical appraisal of evidence about the effect of intervention is what we are going to see. These are the 4 main clinical queries you have. So for intervention, to identify the effect of intervention, we break the question into 4 parts by using PICO, that is patient or problem, intervention or management strategy, comparative intervention, and outcome measures. So this is the one way we use for effect of intervention. And randomized trials, readers of clinical trial can ask 3 questions to discriminate between those trials that are likely to be valid and those that are not, potentially seriously biased. So as you all know, bias is systematic deviation from the truth. So we need to raise 3 questions to understand this. So the first question will be, were treated and control groups comparable? So comparability can only be assured by randomly assigning subjects to groups. Simple random allocation can be achieved by computer to generate an allocation schedule or coin tossing. Sometimes we also use quasi-random allocation procedures. Subjects may be allocated to groups on the basis of the birth date, height, weight, or something like that. So some studies match subjects and randomly allocate subjects to groups. And this can be like stratified random allocation. You have a population and then you pick a population or samples from each area. So reports of randomized trial will usually explain that subjects were randomly allocated to group. This is very important for you. You pick up researchers which have this randomly allocated group or randomized control study. So this might appear in the title of the paper or in the abstract or in the methodology section, which proves that it is of high quality. It has been done in an effective way. So the second question we need to address is, was there complete or near complete follow-up? Doing clinical trial is hard and often mundane work. Often the hardest part of the trial protocol is planned measure of outcomes, that is follow-up. Most clinical trial involve interventions that are implemented over days, weeks, or months, sometimes years. So following up a patient is very difficult. So we need to see whether the follow-up has been done properly. Usually outcomes are assessed at the end of intervention, and they are often also assessed at one or several times after the intervention has ceased. So trials of chronic conditions may assess outcomes several years after the intervention period has ceased also. So this follow-up of assessment is very important, and we need to see whether the follow-up has been done properly and appropriately, and we have to see the follow-up in the research paper. If they had given follow-up, then it is good. So the more subjects lost to follow-up, the greater potential for bias. How much loss to follow-up is required to seriously threaten the validity of a study finding? So based on the follow-up, if the follow-up loss to follow-up is of 10%, it would not cause much of a problem. So it won't cause much of bias in the study. On the other hand, if it is more than 20% loss to follow-up, then you have to seriously doubt the study, and definitely the study is of biased. So 15% is okay. So more than 15% also you should doubt. So these numbers are sometimes given in the text. Alternatively, it may be possible to find these data in table or results or in summaries of statistical analysis, or it will be given in a flow chart. So studies which do not provide loss to follow-up and which do not explicitly state that there was no loss to follow-up should be considered potentially biased. So the third one we need to see is, was there blinding to allocation of patients and assessor? So there is a reason to prefer that. In clinical trials, subjects are unaware of whether they are being, whether they receive intervention or whether they are being put in a control condition. This is called blinding or masking. So in other way, blinding means the subjects in intervention and control group do not know which group they were allocated to. So blinded subjects can only guess whether they received the intervention or control, whether they have been put in a control condition. This is one important thing you'll see in a paper, research paper. So blinding is very important. So blinding of subject is considered important because it provides a mean of controlling for placebo effect and the effect of polite patient. So how is it possible to blind patients to allocation? How can subjects not know if they receive the intervention or whether they are put in control group? Especially in physiotherapy practice, it's very difficult. So the general approach involves giving a sham intervention to the control group. Sham intervention are those that look, feel, sound, smell, and taste like the intervention but could not affect the presumed mechanism of intervention. So we would prefer to give an alternative exercise or something like that. So in many physiotherapy trials, there is no real possibility of applying a sham intervention because it is not possible to construct an ineffective therapy. Then even moderately resembles the true intervention. That is very true. So in that case, some control of placebo effect may be achieved by providing a control intervention, which, like a sham, has no direct therapeutic effect. So in that way, you can identify it. So we move on to systematic reviews of randomized trials to identify the effect of intervention. So if a systematic review is to produce valid conclusion, it must identify the most relevant studies because they are going to collect and compile very many literature of a particular topic, and they have to produce a balanced synthesis of their findings. To determine this goal has been achieved, readers can ask 3 questions: whether the systematic review is good. So was the quality of reviewed studies taken into account? So here we have to see whether the quality of studies is used, the quality of studies should be focused on. So many randomized trials are poorly designed and provide potentially seriously biased estimates of the effect of intervention. So consequently, if a systematic review is to obtain an unbiased estimate of effect of intervention, it must ignore low quality studies. The next thing is the simplest way to incorporate quality assessment into the finding of a systematic review is to list minimum quality criteria for trials that are to be considered in a review. So it is necessary to apply quality criteria that includes, that is, excluding non-randomized trials. So the systematic review should include randomized trials. And okay, so the systematic review stipulate that a trial must also be subject and assessor blinded. So this is called double blind. An alternative way take into account trial quality in the reviews to assess the quality of trial using a checklist or a scale to score it. So two of these, the Masquerade scale and the Pedro scale, can generate a quality score for the systematic review. If a scale has been used to assess quality, the quality score can be used to set a quality threshold. So they have this minimum criteria to select the research papers to compile it. Was it clear which trials were to be reviewed? One of the strengths of properly conducted systematic reviews is that the possibility of selective reviewing is reduced. So to reduce the possibility of selective reviewing, reviewers should clearly define the scope of the review prior to undertaking a search for relevant trials. So the best way to do this is clearly describe the criteria that are used to decide what sort of trials will be included in the review, and perhaps also which trials will not be included in the review. So it is given in the inclusion and exclusion criteria. Usually it refers to the population, intervention, and outcomes of interest. So the third one is where most relevant studies reviewed. So well-conducted reviews identify most trials relevant to the review question. So if the review does not identify all relevant trial, it may conclude that there is less evidence than there really is. So they have to search for all the relevant studies and compile it and give it to you as a systematic review for you to follow it. So systematic reviews may sometimes miss relevant trials. Causes of missing relevant trial studies include many reasons. So some of the reasons are randomized trials in physiotherapy are indexed across a range of partially overlapping major literature databases. So publications go into different databases. There can be publication bias. There can also be language bias. So what is language bias? It usually means that studies are published not only in English, but other languages. So it is very difficult for you to follow other languages or collect other language research paper to understand your focus. So publication bias also is there, where good research publication is sometimes goes unpublished or goes and be published in a poor or low quality journal. So that is where you don't get good journals, good research articles. So what is the solution? It is desirable that the reviewer perform sensitive searches of several medical literature databases, say at least 2 Medline, Embase, CINAHL, PsycInfo, and at least one of the specialist databases such as the Cochrane Collaboration Central Register of Clinical Trials, Central, or PEDRO. So PEDRO is exclusively for physiotherapy. Further consideration in the recent, when you're reviewing for articles for systematic review, you collect within 5 years ago. Like recent articles should be collected. So you can, in conclusion, when appraising the validity of a systematic review, readers should consider whether the review clearly define the scope and type of studies to be reviewed, whether an adequate search was conducted, and whether the quality of the trials was taken into account when formulating the conclusions of a systematic review. When not all criteria are satisfied, the reader needs to weigh up the magnitude of the threats to the validity of studies. So let's move on to the next one, critical appraisal of evidence about experiences. So the effect of intervention, use the quantitative research for intervention, while the study of experience is based on qualitative research. Why? Though both kind of studies make useful contribution to the knowledge and should be regarded as complementary rather than conflicting, The term experience referring to the phenomena that qualitative research might explore and give you answers. So which also include attitudes, meanings, beliefs, interaction, and processes. Should we look to the qualitative research, we should consider the following three issues when we are going to analyze these. So the first one is, was the sampling strategy appropriate? Why was the sample selected? How was the sample selected? Were the subject's characteristics well defined? So in the qualitative study, we are concerned mainly by the characteristics of participants, as we want to understand a particular phenomena or experience of a particular individuals. So experience, situation, social interaction. So the subject's characteristics should be well defined. And so the sample is selected to contain people with relevant roles, perspectives, or experiences. That is called purposive sampling. So the process of conscious selection of small number of individuals meeting particular criteria. So the researcher should explain why and how the sample was selected. That we'll see in the research paper. Also, as the aim of the study is in-depth and rich insight, the number of observation is not predetermined. Instead, data collection should continue until all the phenomena are emerged. Nonetheless, the researcher should explain why this number is thought to be sufficient. So was the data collection sufficient to cover the phenomena? So was the method used to collect data relevant? Were the data detailed enough to interpret, and why was it being researched? So all these queries we have to look into the paper, and it will be provided. A range of very different methods are used to collect data in qualitative research. They vary from participant observations to in-depth interviews to focus groups, and also to document analysis. All those things can be done. So the data collection method should be relevant and address the questions raised and should be justified in the research report. The use of more than one method of data collection can help to confirm or extend the analysis of different facets of the experience being studied. Enough participants should be interviewed until emerging theories are either confirmed or refuted and no views are obtained. So this is often called the point of saturation, where enough amount of samples are collected. So the point of saturation is when the sample size becomes sufficient. Another important question to ask about data collection is whether ethical issues have been taken into consideration. So the ethics of a study do not have a direct bearing on study's validity, but nonetheless influence a reader's willingness to read and use the findings of the particular research. So were the data analyzed in a rigorous way? So was the analytical part described? Was it clear how the researcher derived categories or themes from the data and how they arrived at the conclusion? Did the researcher reflect on their roles in analyzing data? Everything will be given in the research paper, and you have to see this, whether the analysis was done in a proper way and rigorous way. So an indication of rigorous analysis is that the data are presented in a way that is clearly separated from interpretation of data. There should be sufficient data to justify the interpretation. There are several features that can strengthen a reader's trust in the findings of a study. So one is the use by the researcher of more than one source for information when studying the phenomena, and the use of more than one investigator to collect and analyze the raw data, that is by using multiple coders, also strengthens the study. So critical appraisal of evidence about prognosis. The best information about prognosis is likely to come from a cohort study or longitudinal study, occasionally from systematic reviews of cohort study, but sometimes you can also get useful information from clinical trials also. So individual studies of prognosis, we see was the representative sample from a well-defined population. So the subjects participating in a research, so-called the sample, should be representative to the population we are interested in. That can be granted through the target population is defined by the criteria used to determine who was eligible to participate in the study. It will be given in the inclusion and exclusion criteria, and also ask how the subjects entered in the study. All these things will be given in the method section and abstract. So was there an inception cohort? So inception cohort is to recruit subjects at a uniform, usually early point in the course of the disease. So that prevents the bias that may be caused by either survivor cohort or chronic conditions cohort. So it is very important. You have to understand that whether they were all selected at the initial phase. So was there complete or near complete follow-up? Like clinical trials of effective therapy, prognostic studies can be biased by loss to follow-up. Bias occurs if there is loss to follow-up, on average different outcomes to those who were followed up. Losses to follow-up of less than 10% are unlikely to cause seriously. It cannot distort estimates of prognosis, while losses to follow-up of greater than 20% are usually of concern, particularly if there is any possibility that outcomes are being influenced during the follow-up. So systematic review of prognosis is very similar to that of intervention, systematic reviews of intervention as we saw. That is, it is useful to ask if it was clear which trials were to be reviewed, if most relevant studies were reviewed, and if the quality of the reviewed studies were taken into account. So critical appraisal of evidence about diagnostic test. So this is the fourth one. So questions about diagnostic accuracy are best answered by cross-sectional studies that compare the findings of test in question with the findings of a reference standard or a gold standard. So assessing the validity of individual studies for a diagnostic test was a comparison with an adequate reference standard. So were the findings of the test compared with the findings of a reference standard that is considered to have near perfect accuracy? Was the comparison blind? Were clinicians who applied the clinical test unaware of the findings of the reference standard? They should be blinded. And did the study sample consist of subjects in whom there was diagnostic uncertainty? So was the sampling of consecutive cases satisfying clear inclusion and exclusion criteria? We should not demand perfection from clinical research because it is generally not attainable. Instead, we should look for studies that are good enough to make clinical decision for you to practice. So what I explained is for intervention, experiences, prognosis, and diagnosis, you need to look for researchers, particularly systematic review, RCTs, meta-analysis, cross-sectional studies, cohort studies, to understand and practice effectively. So evidence will make you or keep you updated in your practice. Thank you.
Thank you, sir. Thank you for the wonderful presentation. It was very thoughtful and insightful presentation, and this will be surely implemented in our clinical practice in the physiotherapy guidelines, sir. Thank you for the
Definitely. I thank you for the wonderful opportunity. Thank you very much.
So now we have on dais Dr. Naresh. So we'll be starting with the presentation. Very warm welcome, sir. So Dr. Naresh, he is a senior lecturer in the School of Rehabilitation Sciences, University Sultan Zainal Abidin, Malaysia, having more than 22 years of experience in the field of physiotherapy with a teaching experience of 14 years in Malaysia. And he has authored and co-authored 40 articles published in the index journals, and he has few active research grants in UNISA. And similarly, he is also associated with the Sports Council of now, Malaysia, and he has been also awarded as the best reviewer of life science and pharma research and International Journal of Pharma and Bioscience for the year 2021. So we'll go ahead with the session. The dais is yours, sir.
Right. Thank you very much to the moderator. Is my voice clear?
Yes, sir. Your voice is audible, sir.
Thank you very much.
Thank you, sir.
A very good afternoon to all the participants, or good morning from wherever you are. I'm Dr. Naresh Bhaskarraj, Senior Lecturer from University Sultan Zainal Abidin. I'd like to talk about isokinetic training in osteoarthritis of knee, which was a research topic which we did in Malaysia. So I'll be covering on mainly the introduction about osteoarthritis, a few literature reviews regarding isokinetic training, because it's not very common you see an isokinetic training being used in osteoarthritis of knee. So there are very few studies, but still I'd like to review the literatures which are available. And then what are the methods and training in isokinetic, what you can do with an isokinetic device, what are the effects, especially in the form of data, and the references will be the last part of my presentation. All right. So as most of us, since being in physiotherapy field, we know about osteoarthritis, which is very, very common disorder, right? It's a degenerative joint disorder, a very common disorder of knee, which is causing arthritis, is our osteoarthritis of knee, right? Very, very common. So it affects almost 15% of the human population globally, and the percentage has been increasing it's always on the rise, right? This is very old study. Now, if you see the latest one, the incidence or the prevalence of osteoarthritis is very, very high because of overweight and obesity and a lot of other things, right? And it is already doubled, and it is going to double further when we go to 2030 or 2050. You're going to see too many cases of osteoarthritis of knee. The main reason for that is we are having a huge number of elderly population due to the advancements of medical field. So we are having a large amount of elderly population, and especially these obese individuals with changes in your diet pattern, changes in a lot of whatever we eat and whatever environmentally modified foods. We are having a lot of obese individuals, especially if you talk about Malaysia. We have a very high incidence of childhood obesity in Malaysia, right? Childhood obesity is very common, very high in Malaysia. So when you consider these persons, the childs are going to become an adult and then an elderly. So you expect a huge number of patients with osteoarthritis of knee in the near future, right? And this is again Malaysian data, which says we are going to expect a 269% increase of people more than 65 and above in Malaysia by 2040, right? So you cannot stop them from becoming old. That's beyond our control, and you cannot ask them to die early. That's not ethical, right? So we don't have an option. We have to come out with some form of rehab. That's why if you see World Physiotherapy, WHO, they came out with this rehab to 2030 concept, because we need more people for rehab. We need more people who can come out with some evidence-based practices to come out to help these individuals come out, right? So knee osteoarthritis, again, is very, very common in the population, right? So if you look at the pathogenesis or pathology of osteoarthritis, it comes due to two main factors. One is the abnormal stresses and the abnormal cartilage, right? So you can have an abnormal stress or you can have an abnormal cartilage. So any person who's having an abnormal stress can also have an osteoarthritis. Person who's having an abnormal cartilage can also have an osteoarthritis. It can be anywhere. It can not only knee, it can be in hip, it can be in your spine osteoarthritis, anywhere you can get osteoarthritis. We are talking more on knee because it's a weight-bearing joint, right? So what are the factors for abnormal cartilage? Why your cartilage becomes abnormal? Number one is very, very common is aging, right? Once you become older, the water content or the fluid content of your cartilage goes down and the cartilage starts to break, disintegrate. So you land up in an abnormal cartilage. The second is your genetic and metabolic diseases. Any metabolic disease, any genetic disorders can cause, like collagen disorders, or there are many disorders, can cause changes in cartilage, which is abnormal cartilage. Any inflammation, right? You have a septic. Can you go back to the previous slide? Okay. So any inflammatory disorders can be septic arthritis. It can be any form of infective arthritis. There are many arthritis which can affect the cartilage, right? And then your immune system, right? So all these can cause an abnormal cartilage. Let us come to the abnormal stress. So abnormal stress, especially as I told you before, when you're obese, right? There is an unusual, very extra stress on your cartilage, right? So this is putting a lot of load. The cartilage is very normal, but there is too much of stress on the cartilage, which the cartilage is not able to respond or withstand. Anatomic abnormalities, maybe your femur, the condyles are not properly developed, or there is structural abnormality. Microfractures and bone remodeling due to too much of stress. You are standing, you're walking, you're running, you're a sports person, you're putting a lot of stress on your knee joint where there is too much of remodeling, refractures, microfractures, which you cannot see through an X-ray, right? So these also can cause abnormal stresses. Loss of joint stability due to ligament injuries. You can be a sports person involved in football or some other, you fall down, you get hurt, you have an ACL rupture, the ACL is being reconstructed, but you cannot get the same stability which you're supposed to have before, right? And then trauma is an accident which, once you get your once you are in accident, whatever you have a fracture, you are not going to get your 100% same structure back before accident. So all these are going to put an abnormal stress on the cartilage, which means it is going to compromise the cartilage. The cartilage is compromised, so there are going to be a biophysical changes and also a biochemical changes. There is a lot of changes in your enzymes. There are many enzymes, COX inhibitors, so many things are there. And because of this, your cartilage is going to break down. And that, if the cartilage is broken down, the bones, the periosteum is already in contact with each other, and you see there is going to be a very high severe pain, because the periosteum is very sensitive. It has got a lot of sensory nerves, and these sensory nerves, once it starts to rub each other, it is going to cause a severe pain in the knee joint. That's where patient land up with a lot of pain. Can you next slide, please? Thank you. All right. So we are talking about only about cartilage, right? Muscle strength, pain, range of motion. But one important part which we don't usually address is the proprioception. So the knee joint is a very important joint for proprioception. Proprioception is your joint position sense and movement sense, right? So what is proprioception? Unconscious perception of movement and spatial orientation arising from stimuli within the body. So what is your position of your body, your hand, without your conscious? So this is unconscious. This is proprioception. This proprioception is also lost when there is an osteoarthritis, which most of the therapists, we ignore checking proprioception in osteoarthritis. What happens when you don't have a proper proprioception? The chance of fall is becoming higher and higher. The stability becomes more and more less. So once the stability is less, then the patients land up in frequent falls, or there is going to be a lot of injury. It's like a cycle, right? So you lose stability, you injure more, again your stability is lost. So somewhere we need to break this cycle, right? And there are a lot of studies which have already proved that proprioception is not normal, is very much affected, impaired in osteoarthritis of knee, whether it is unilateral or bilateral. So what is as I told you, there's a cycle. Once you have a proprioceptive loss, your muscles doesn't start not function properly, doesn't contract. So there is going to be a muscle weakness, and it's going to repeat, right? Next slide, please. Okay. So what is the impact of osteoarthritis on human population? So usually the onset is at the age of 60, but it is now reducing. So if you look at the ACR criteria, it's almost 40 years and above, you can have an osteoarthritis. And if you have a knee pain and other criteria, you are diagnosed to have a osteoarthritis, right? Symptoms of knee osteoarthritis increases with increased loading of the joints. The more and more you load the joints, the more and more it is going to get severe, right? And this is in animal study, the other one. Cartilage cell death occurs at 6 hours of continuous repetitive loading and 3 years of static loading, which means if you load the cartilage statically for 3 hours, you can see the chondrocytes are going to die. The chondrocytes are the cartilage cells, they are dying. Or if you are repeatedly loading, these are animal studies, not a human study. So if you are repeatedly loading the cartilage for 6 hours, you can see some cartilage cells are dying. So which means loading is good for bone, but not good for the cartilage. So you have to be very, very careful when you're loading a joint which is already diseased, or especially in osteoarthritic. Okay. And it was also found out that females are more susceptible for osteoarthritis when compared to males, right? And when you take the prevalence studies, osteoarthritis is more prevalent in elderly females compared to elderly males. So what is the reason for that? Can you go to the next slide? All right, so these are some of the reasons, not many, there are many reasons. These are some of the reasons why osteoarthritis are very, very common in females. Number one, compared to males, they have a very, the quadriceps is quite weak, right? I'm not telling that very weak. Compared to males, their quadriceps are quite weak. So that is one reason. The second, the volume of the cartilage, right? The volume of the cartilage is less compared to males. Males have a little bit larger cartilage volume, or a thicker cartilage compared to females, right? Third, there is a genetic reason, right? Nowadays, people are going into genetics, right? They are finding out, is there anything? So osteoarthritis will be classified into a genetic disorder later, because they are already doing a lot of genetic studies to find out, is there any possibility that it could be due to an altered gene, or a gene which is not in a proper shape, or any abnormalities, right? And the last one is loss of cartilage due to low levels of insulin-like growth factor, IGF-1, which comes with obesity, right? When you're overweight and your obesity, your insulin resistance goes down. So this can also cause the cartilage to loss of cartilage. So these are 4 main reasons why the elderly females are getting osteoarthritis compared to males, right? Can you go to the next slide? So these are common comorbidities. Comorbidities is the problems which are associated with people who have osteoarthritis. One is depression because of pain. They are not able to socialize. They cannot move out. They cannot climb the steps. You cannot use the toilet. So, and number 2 is high cholesterol levels, right? As I said, overweight, obesity, they have high cholesterol levels, and most of them are diabetic, especially in Malaysian population. Also, you have very high case of diabetes. They have CADs or coronary artery disease, and they also have ulcerative colitis because they usually take many painkillers to come out with to reduce the pain, right? These are some of the comorbidities which are associated with osteoarthritis of knee. Can you go to the next slide? All right, so what is isokinetic training? Most of us, we have just read about isokinetic training, same kinetic velocity or speed. So contraction where the velocity is a constant, right? That's right. So previously, these isokinetic devices have been very commonly used only for measuring the muscle strength. It was usually used for measuring the muscle strength, very, very perfect. How to measure the strength of quadriceps, hamstring, right? But later it was started to use in training, and especially it is very commonly used in sports injuries, especially ACL reconstruction, ACL injuries. They use a lot of isokinetic training. All right, so it has been used in many populations. You can see it was used in male, female, children, elderly, athletes. Elderly, not many studies, but there are quite a few studies which I'll read. So even with cardiopulmonary disorders, they can do neurological, musculoskeletal. It has been applied in many specialties, right? But not eventually. Only is because of the cost of the equipment, right? So that's the only hindrance for isokinetic training, right? Okay, next slide. Okay, this is about the literature review part. I don't want to quote any studies. I'd like to go into the forest plot, like previous speaker told about. Dr. Paul is my lecturer, so he just told about the meta-analysis, right? It is on the top of the evidence, right? So I try to pick up the meta-analysis because this is what gives you the perfect evidence of whether you can use an isokinetic training or not. Is it eligible to use an isokinetic training? So you have to look at a meta-analysis or randomized control trials if you want to have a very good evidence for practice, right? So based on this is a study done by Caudry et al. I have also done one meta-analysis, which I'll show you later, but this is the latest. Mine is a little bit old. So this is the latest 2016 meta-analytic review by Caudry. So this is a forest plot for people who are not familiar with meta-analysis. When you do a meta-analysis with a lot of data, you can come out with a forest plot. So this forest plots will tell you, these are the graphs which tell you whether the studies are favoring isokinetic or they are not favoring isokinetic, right? So this is isokinetic muscle strengthening on pain, especially in osteoarthritis of knee. You can see these are all the Huang et al. 40B. These are the researchers studies, and Gur. They are all the names what you study is an authors. So if you look at the boxes or the diamonds, it is almost towards, it is favoring isokinetic training, which means isokinetic training is effective in reducing the pain, right? So that's what this meta-analysis says. So when you say it's a meta-analysis, which means you can take the evidence. It's a very strong evidence which shows that isokinetic training can reduce the pain of the knee joint, which is coming from the knee joint due to osteoarthritis. Can you go to the next slide? All right, this is the study which was done by me, meta-analysis which was done by me personally. Again, you can see this is for the strength. You can see there are studies which favor the isokinetic training compared to other exercise. So usually when you do a meta-analysis, we compare with other exercises and isokinetic training. Can you go to the next slide? All right, so this is on walking speed. Again, this is a meta-analysis done by the same author. You can see again, there are many studies which favor isokinetic training. And next slide. All right, this is on WOMAC. WOMAC is a questionnaire, Western Ontario McMaster's University Osteoarthritis Index. This is on a specific disability score. Again, it shows it favors isokinetic training, which means it can reduce the disability of knee osteoarthritis. Next slide. Again, and this is another outcome measure, which is called Lekushny Index. Again, this forest plot also shows the evidence that isokinetic training can be used for osteoarthritis of knee. Can you go to the next slide? All right. So what we did a research in the University Science Malaysia, which is one of the apex topmost universities in Malaysia. We used isokinetic device to check what is the effect on the osteoarthritis of knee. So we recruited around 72 patients with osteoarthritis based on an inclusion criteria. Our inclusion criteria was based on ACR, American College of Rheumatology criteria. There are many criteria which I'm not going to go too much because of time. So you can refer back to ACR criteria for osteoarthritis. And we also followed the Kellgren-Lawrence grading using the X-ray. So we recruited grade 2 and grade 3 patients. So what we did was we analyzed, this is what the picture, what you see is your Biodex 4, which is an isokinetic device. And this is the patient position. The patient is strapped. And this is the machine, the white, what you see on the right side of the patient is your dynamometer. So you can see the patient is wearing a cuff because we measured proprioception as well. It's not just the strength we have measured, we measured proprioception. Proprioception can be measured in 3 ways. One is threshold to detect passive movement, active repositioning error, and passive repositioning error. So how much we set the machine, so the machine will be moving just 0.5 degrees per second, very, very slowly, 0.5 degrees per second, the machine will move. So the patient has to, once the patient feels that the knee is moving, he has to stop the device, right? So it means we will see how much error he is making, whether he's able to press the button at 0 degree or he's going 5 degrees and then pressing the button. So how much error he is doing. Same thing, we do 3, threshold to detect passive motion, active repositioning, and passive repositioning error. And then we do a muscle strength testing with this, right? So this is what's our assessment. And we used the same device for training as well. So I'll explain the protocol later. Can you go to the next slide, please? So it's not only that, we have also analyzed the gait of the patient by fixing all the markers. And we have the DELSIS motion capture system through which we capture the movement of the knee joint. How is the movement before and after the isokinetic training? And you can see the patient is standing on a platform. That is the force platform, which will measure the force which is coming from the knee joint, right? So this is what the analysis which we did. I'm not going into the details of a lot of other things. Just the basic thing we did, I'm sharing with you all. Can you go to the next slide? All right, so as I told you, this is what we analyzed. We analyzed muscle strength using Biodex. We analyzed proprioception using Biodex. And this was our isokinetic training protocol, right? So any isokinetic training protocol, we have a warm-up for 5 minutes before, because it's a little bit strenuous. It's not like our ordinary isotonic or isometric. It's a little bit strenuous. The patient has to put his 100% effort to push the lever. So we need to do a warm-up and we need to do a stretching. And then you can see we gave 5 concentric and eccentric contraction for knee extensors and flexors at 2 velocities. We have 90 degree per second and 150 degree per second. Why I didn't choose lower velocities is because the lower velocity, if the speed is very less, the friction will be very too much. So since already the cartilage is not there, we don't want to risk the patient losing out more cartilage on this. So we choose a little bit of high velocity so that the patient doesn't have problems. So this is our protocol which we use. So what was the effect of our study? Can you go to the next slide? All right. So you can see the average peak torque. Average peak torque is one parameter which will tell about the strength of the muscle. So you can see there was a gradual, you can see 5 measurements, 5 bars, right? So one is for pre, another one is 5th week, another one is 10th week, another one is 14th week and 18th week. So we measured periodically, and till 10th week we did the training. After 10th week there was no training. So you can see a gradual increase in the strength of the muscle at 180 degree per second in the quadriceps. So this is an increase in your strength. Can you go to the next slide? Okay, so this is again for flexors, hamstring muscles, you can see. So for hamstring muscles, again, you can see the quadriceps has a very high improvement in the strength. And for flexor hamstring, again, there was improvement in the strength. Can you go to the next slide? All right, even the range of motion increased and it got maintained, means it didn't decrease, it got maintained, because it was done only from 90 to 0. So you can see almost it has reached 90 to 0. There was nothing much you can do, right? So because we don't want to injure the knee, so we didn't go for too much of extra. We just started from 90 to 0. Next slide. Right, this is the step time which I told you when we analyze. Just one parameter I want to discuss. So you can see the step time also increased, which means the time duration which the patient takes, it was very less, but once after you do your isokinetic, it started increasing. So and there was at the second follow-up, there was a little bit reduction, but not much reduction in the step time. Okay, next slide. All right, so this is the proprioception we are going to talk about. So you can see when the patient, the first bar shows the error the patient has made when we do the pre, but later you can see the error has already come down gradually. Even it was after follow-up also, after we stopped the training also, the error was not that much. Next slide. Okay, this is passive repositioning error. Again, another again, another parameter for proprioception. You can see the error rate gradually decreased across your levels of measurement. Next slide. This is how soon the patient was able to detect the movement. Again, average 10 degrees, they made an error, but once we did our training, they reduced the error to almost 5 degrees or less than. Even 5 degrees is considered normal. Even you can make an error of 5 degrees, especially when that equipment's, right? So 5 degrees are compared to almost normal data. Next slide. Okay, you can see the pain, as I told you, whatever in the review of literature, even the pain has gradually reduced. The pain score was made high in the pre, and it has reduced. Next slide. Next slide. Okay, stiffness. All right, stiffness also decreased. This is what patient has told us, because OMAC is a self-administered questionnaire, right? What the patient perceives. So they perceived less stiffness after isokinetic training. Next slide. Okay, difficulty in doing works. That is another criteria in your OMAC score. So even that has becoming less. The difficulty was less after isokinetic training. Next slide. Okay, so why do we see these effects of after isokinetic training? Because as you all know, isokinetic training is mostly velocity dependent. So since velocity dependent, it is going to increase the firing of motor neurons rather than you do your conventional physiotherapy or your loading isotonic exercise. This increases the firing of motor units. There was a lot of neuronal adaptations. The cross section of the muscle also increased, right? Even though we didn't measure, it was more than what was previously seen. Next slide. Okay, and since how did the proprioception improve? Because we are substituting the muscle spindle or the Golgi tendon organ instead of the ligament. So since the ligaments are already lax, we want some other structure to take over. So when you are training with isokinetic, you are training your GTOs and your muscle spindle to fire, to activate more so that it can take care of your proprioception, right? And also the receptors, mechanical receptors, which are there in the ligament, also get response to the eccentric and concentric concentration. Next slide. Right, so this is the end of my talk or my presentation, and these are some of the references for you to check. So thank you very much. If there are any questions, I'd like to take.
Yes, sir. It was a very wonderful presentation, sir. We have few questions from the panelists and the audiences. Sir, are there any preliminary tests being performed before the patient is going to be in the particular equipment?
We have a very strong inclusion exclusion criteria. If the patient has got any cardiorespiratory disorders which makes them unsuitable for the isokinetic, we avoid. It's not just hypertension. We are talking about any any bypass or something. And usually we have an orthopedic surgeon who will check all these criteria and include. So as for us, we don't have any problem in. So the patients will go through a very strong inclusion and exclusion criteria before we start to give isokinetic training.
So since this equipment is being utilized in Malaysian population, as a physiotherapist from the India, if it is being introduced into the Indian population, so what are the things that are to be addressed by the physiotherapist to the Indian population? So what should the physiotherapist know about the equipment?
First thing is the equipment is a little bit expensive till the prices have not come down, but it has come down. It has come down a lot compared to the previous versions. So now once people start to use more and more, it's like handphone. So once you start to use more, the prices will automatically come down, right? So the prices, the problem is with the prices, right? That's why it doesn't suit Indian population. Number two, in Malaysia, it is mostly funded by the hospitals or from the grants monies. Whatever grant we receive, we try to use the. So in India, we don't have that grants to buy these equipments, costly equipments. But the only thing, if you are a physiotherapist and if you are ready, or if your hospital is ready to purchase or your center is ready to purchase, the only thing is you need a little bit of training on isokinetic. It's not that easy like you operate any of the equipments. You need to practice because the fixing, the setting of the machine takes a little bit of training, repeated training. That's the only thing you need to take care of. There is nothing like you have to go abroad to learn your isokinetic device. No, just need to use it, right? Just need to use the equipment. So once you use it, you will be very familiar with the operative systems.
Yes, and we have one more question. Could this be utilized for the post-operative total knee replacement rehabilitation? Can this be utilized?
There are now studies as such on knee replacements, but it can be tried. There is nothing wrong in trying. Only thing is you cannot try it in the immediate period. You need to wait for the processes to set properly, and then you can try. But I will always prefer to keep the velocities. You have to the mainly thing is the parameters you choose have to be very, very careful so that it doesn't loosen out your prosthesis, right? So total knee replacement is what we want to see, that your goal is very important, whether you want to, because the pain is already taken off after replacement. So the only option you have is to improve the muscle strength, right? And proprioception, maybe you need to assess proprioception after replacement. So these two things you can think of implementing these isokinetic very much, but only thing is you have to be very, very careful when you're choosing the parameters, right?
Yes, sir. And we have a few more questions. Are there any specific age criteria that the equipment has to be used?
Not really. We don't have any age criteria. So as far as I told you before, it was like usually the ACR criteria we follow, which is American College of Rheumatology criteria, which says 40 years and above, the patient should have knee pain. The patient should have a stiffness of less than 30 minutes. And on an X-ray, they should have a joint space narrowing. So this is the ACR criteria. So we follow this ACR criteria. Any person above 40 years, you can use. There is no limit unless and until your exclusion criteria, there is no complication with the patients, you can go out with isokinetic training. There is no problem.
Okay, sir. Thank you so much, sir. It was a very immense pleasure to have you on board for this wonderful STRIDE webinar. Thank you, sir.
Thank you so much. I thank all the committee members and management of Saveetha for giving me an opportunity to share my knowledge on isokinetic training. So if there is any errors from my side, I apologize. So thank you very much.
Okay.